Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of. Okay, today's discussion is very important topic, that is inflammatory bowel disease in pediatrics. This topic is very important as we can see many questions has been asked from this topic, and this topic is also important for pediatric practice in journal. So IBD includes Crohn's disease and ulcerative colitis, as we all know. So both are characterized by chronic idiopathic intestinal inflammation with exacerbation remissions. Basically, it is intestinal inflammation. So Crohn's disease and ulcerative colitis are two spectrum of this disease, all we know. So next important thing, bimodal distribution. Actually, IBDs presents in pediatric age group, that is 10 to 20 years, and second peak in 50 to 80 years. Basically, this disease is of pediatric and geriatric population. That's how you can remember this. In adults, it is also found, but yeah, in pediatric and geriatric population, that is 10 to 20 years, early onset, and second peak occurs at 50 to 80 years. Important point to note, 25% of patients present with before age of 20. So in less than 20 years of age, 25% of patient present. So this is important consideration. Indeterminate colitis accounts for 10% of pediatric cases, means colitis is present but we are not able to classify it. Indeterminate colitis. Okay, so what is the etiology or pathogenesis? Are there any genetic factors for this inflammatory bowel disease? Yes, 7 to 30% risk among affected relati individuals relatives. Okay, if any patient is affected, his or her relative has 7 to 30% chance of having inflammatory bowel disease. If both parents are affected, more than 35% chances. If monozygotic twins are affected, indigozygotic 36% for Crohn's and 16% for UC. As you can see, Crohn's disease is more genetically predisposed. Are there any genetic disorders which are linked to IBD? Yes, they are. Turner syndrome, Hermansky-Pudlak syndrome, glycogen storage disease type 1b, immunodeficiency. Is there any gene available? Yes, NOD2 gene. This is first identified IBD risk gene. So from this slide, what is important thing for us? 70 to 30% risk among affected individuals, and 35% if both parents are involved, and more risk in Crohn's disease. Some syndromes we have to remember, like Turner syndrome, Hermansky-Pudlak syndrome, glycogen storage disease type 1b, and one gene we have to remember, that is NOD2 gene, that is first identified IBD risk gene. Are there any environmental factors for IBD? Yes, they are. Gut microbiota changes linked to IBD. So, Western diet, increased antibiotic use, vaccination rate, and reduced exposure to microbes in early life. So, basically, this is like Western lifestyle. So, Western lifestyle, which contains of diet and reduced exposure to microbe in early life, leads to some of pathogenesis of these inflammatory bowel disease. Okay, the important consideration, cigarette, as we are aware of, this increases risk of Crohn's disease and protects against ulcerative colitis. So don't have cigarettes because it increases Crohn's disease, but somehow it decreases risk of ulcerative colitis. This statement has been tested multiple times. Cigarette smoking has increased risk factor of Crohn's disease and protects against ulcerative colitis. What are the clinical features of this IBDs? In pediatric population, colonic involvement is more common. So in colonic involvement, chronic diarrhea, abdominal pain, bloody stools, poor growth and decreased height velocity. Basically, it looks like malabsorptive pathology. So, is there any extra intestinal manifestation of these IBDs means outside of GIT? Yes. Extra intestinal manifestations more common in Crohn's disease. This is very important. So, what are these? Like arthritis. So, it is migratory peripheral arthritis, large joint, ankylosis spondylitis, sacroiliitis. What are the manifestations seen in skin? Erythema nodosum, pyoderma gangrenosum, and hepatobiliary sclerosing cholangitis. Renal glomerulonephritis, thromboembolic disease like central thromboembolism in children. Are there any serological markers available for these IBDs? Yes. P-ANCA is positive in 70% of ulcerative colitis patient and anti-Saccharomyces cerevisiae antibodies ASCA found in 55% of Crohn's disease patient. Just remember P-ANCA is seen in 70% of UC and ASCA seen in 55% patient of CD. So this is very important thing. Just remember these things. Serological markers are important as we see later. How you will diagnose these disease based on symptom, history, radiological, endoscopic and histological findings. So, if we happen to do X-ray in these disease, X-ray shows air fluid level and bowel dilation. Contrast studies like identify inflammation and differentiate Crohn's from UC, and endoscopy and biopsy for definitive diagnosis. So, if you have to do definitive diagnosis, endoscopy and biopsy is the thing. How you will manage this condition? Medical treatment and surgical treatment are option. In medical treatment, aminosalicylate and corticosteroids, they basically control inflammation. Immunosuppressive drugs like azathioprine, methotrexate for long-term management, and biological therapies like TNF-alpha inhibitors, infliximab are for long-term management. Surgical treatment, is there any surgical treatment? Yes. For Crohn's disease, basically surgical treatment is for complications like stricture, fistula itself, and ulcerative colitis, colectomy can be curative in severe cases. So we have to provide nutrition support like enteral nutrition, total parenteral nutrition for complicated cases, and we have to monitor the patient. Okay, what is the prognosis? These IBDs are chronic condition with lifelong management. Remission exacerbation occurs unpredictably. Complications like stricture, fistula, abscess, these are more common in Crohn's disease. As we saw earlier also, Crohn's disease is also having more extra-intestinal manifestations. Cancer risk is also there with poor growth and delayed puberty. Okay, so, this was a journal discussion of inflammatory bowel disease. Obviously, we will discuss them separately. Just look at this table. This table is showing difference between Crohn's disease and ulcerative colitis, and this is very important. Okay, so just see, Crohn's disease, rectal bleeding is more common in Crohn's disease. Just remember abdominal pain, abdominal mass, growth failure, perianal disease. These are more common in Crohn's disease. Erythema nodosum, mouth ulceration are also common. Ileal disease is common. Stomach esophageal disease. Just remember the things which are more common in one of the disease like Crohn's disease. By this way, you will be able to remember this. Like, just remember abdominal pain, mass, growth failure, perianal disease, erythema nodosum, mouth ulceration, stomach esophageal disease are more common because the Crohn's disease is more systemic or more widespread involvement. So it starts from mouth ulceration to stomach esophageal disease, although abdominal pain, mass, growth failure till perianal disease. So this is very important for Crohn's disease. Just remember for ulcerative colitis, it is actually rectal bleeding, diarrhea, mucus and pus, and this is rectal involvement and pyoderma gangrenosum, thrombosis, colonic disease 100%, and other are less common. So just remember, I am just putting some words for to easily remember, like ulcerative colitis. Just remember, this is a rectal bleed, diarrhea, pyoderma gangrenosum, and thrombosis. Just remember these keywords for ulcerative colitis. Again, I am repeating: rectal bleed, diarrhea, pyoderma gangrenosum, and thrombosis. The rest of the things like abdominal pain, abdominal mass, growth failure, perianal disease, erythema nodosum, mouth ulceration, and stomach esophageal disease and ileal disease are more common in Crohn's disease. Just go through this important table once again and you will remember all of these, and this is very much important. Okay. Uh, Next part of this, strictures are more common. Fissures, fistula are more common in Crohn's disease. So the complications are more common in Crohn's disease like stricture, fistula, fissure. Toxic megacolon, because colon is the more colonic involvement is, as we can see, colonic involvement is 100% in ulcerative colitis. So toxic megacolon is more in ulcerative colitis. Sclerosing cholangitis is more common in ulcerative colitis, and the risk of intestinal cancers are increased in Crohn's disease. Skip lesions are more common in Crohn's disease. Why? Because this is having widespread involvement. So skip lesions are there. Transmural involvement. Yes, Crohn's disease has transmural. Crypt abscess are more common in ulcerative colitis. Granulomas are more common in Crohn's disease. Linear ulceration are more common in ulcerative colitis. And P-ANCA positivity is seen as 70%. So for this also we will remember for ulcerative colitis, because this is easy to remember. Just remember toxic megacolon, just remember sclerosing colitis, just remember crypt abscess, just remember linear ulceration, and just remember P-ANCA is 70%. Okay, so just remember all these things for ulcerative colitis, like toxic megacolon, sclerosing colitis, crypt abscess, linear ulceration, and P-ANCA 70%. The rest of the things like stricture, fissure, fistula, like risk of intestinal cancers, like skip lesions, transmural involvement are more common in Crohn's disease. To summarize, just remember ulcerative colitis thing once more: rectal bleed, diarrhea, pyoderma gangrenosum, thrombosis, toxic megacolon, sclerosing cholangitis, crypt abscess, linear ulceration, and P-ANCA 70% cases are more common in ulcerative colitis. Okay, so we will see ulcerative colitis in detail. So in ulcerative colitis, what we able to see, ulcerative colitis is a chronic idiopathic inflammatory disorder of colon sparing the upper GIT. Okay, so now it is easy for us to remember because colonic involvement is 100% in ulcerative colitis. So it begins in rectum and may extend proximally. If limited to rectum only, this is ulcerative proctitis. And if it involves entire colon, this is pancolitis. So 50 to 80% of pediatric patients have extensive colitis. So just remember from this slide, ulcerative colitis is mainly colonic involvement and rest of GIT generally spared. Extensive colitis is seen in ulcerative colitis. So ulcerative proctitis is less likely. Incidence we don't have to remember, slightly more common in male than female. So just remember for UC, male ratio to female ratio is more, male are more involved. What are the clinical manifestation? Though we have seen the general clinical manifestation of IBDs and we have seen the tabular difference between ulcerative colitis and Crohn's disease, let's look the some specific symptoms to ulcerative colitis. Okay, as we discussed earlier, blood, mucus and pus in stool are seen in UC more commonly. Diarrhea, yes. Tenesmus, urgency, cramping abdominal pain, because this is colonic involvement. So colonic features of tenesmus, urgency and cramping abdominal pain are more. Mode of onset can be insidious or acute fulminant. If it is fulminant colitis, okay, so you will see the features of fever, severe anemia, hypoalbuminemia, leukocytosis, and more than 5 bloody stools per day for 5 days. So this is important. How this is important? Just understand. A patient comes to you with more than 5 bloody stool per day for 5 days. 5 bloody stool per 5 days with fever. You do blood investigation, severe anemia, hypoalbuminemia and leukocytosis. What is the diagnosis? So this is maybe fulminant colitis feature of ulcerative colitis. Just remember this thing, this is very much important. If symptom beyond 1 to 2 week, so it suggests IBDs. So growth faltering or less growth is also seen, like anorexia, weight loss, iron deficiency and folate deficiency. Extra-intestinal manifestation generally are more in Crohn's disease. But what are the extra-intestinal manifestations which are more in ulcerative colitis? Pyoderma gangrenosum, sclerosing cholangitis, chronic active hepatitis, ankylosis spondylitis. This is very important statement and has been tested many times in um, professional or practical exam. So just remember, again I am highlighting and writing of this important consideration: pyoderma gangrenosum, sclerosing cholangitis, and chronic active hepatitis and ankylosis spondylitis. Okay, so just remember by this mnemonic, you can make your mnemonic also. A postgraduate, a postgraduate went to Supreme Court for CH for a case on 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 AS you remember at anything for ulcerative colitis. Ulcerative colitis. Just remember this mnemonic. PG, SC, CH and AS are more common in ulcerative colitis. Okay, Montreal classification for extent and severity for ulcerative colitis. There is a classification named as Montreal classification for ulcerative colitis. Just remember the important point, like E1. E1 is proctitis, E2 is left-sided, E3 is pancolitis. Okay, so just remember these things. E1 is proctitis, E2 is left-sided, and E3 is pancolitis. S0 for remission, S1 mild, S2 moderate, S3 severe. Don't go deep into these description of this. Just remember it is Montreal classification is used for extent and severity of ulcerative colitis. Is it has component of E1, E2, E3. and S0, S1, S2, S3 are these component. Okay, this is Mayo endoscopic score for ulcerative colitis. Again, for ulcerative colitis, which score is used? This is Mayo endoscopic score. So score 0 is normal, score 1, score 1 is mild erythema, score 2 is moderate, and score 3 is severe and spontaneous ulceration. So as we can see, this is normal looking mucosa, this is mild erythema, score 1. This is moderate erythema, absence of vascular pattern as we can see in this, and score 3, it is bleeding and ulceration. So just remember this picture. This is Mayo endoscopic score of ulcerative colitis. This is normal, this is 1, this is loss of vascular pattern 2, and this is 3, like severe spontaneous bleeding and ulceration. Okay, so what is the course and prognosis of ulcerative colitis? So, chronic relapsing course with period of remission and flare. This is obviously chronic disease. So, 5% children with UC have prolonged remission longer than 3 years, and 25% of children will require colectomy within 5 years of diagnosis. Is there any risk factor for colon cancer? Yes, the risk factor for colon cancer is increases after 8 to 10 years. So again, in UC, colonoscopy screening is recommended after 8 to 10 years of dysplasia. So this statement underlines the significance of all our discussion. Ulcerative colitis, colonoscopy screening is recommended after 8 to 10 years of dysplasia. Okay, are there any differential diagnosis, or are we diagnosing it accurately? Are there any differential diagnosis? Yes, infective colitis, maybe allergic colitis, cytomegalovirus, HUS, IG vasculitis. Yes, these can be differentiating factor or differential diagnosis of this condition, like CMV you can see, HUS you can see. Just remember key point of these thing, and you will be easily able to differentiate among these. Okay, this is ulcerative colitis phenotype by Montreal classification. Okay, we have seen E1, E2, E3 in our previous table. So this is E1, E2 and E3. So just remember how they presents. So E1 is proctitis. Basically, it is actually rectal involvement. E2 is left side and E3 is pancolitis. Symptoms will be according to this. If rectum is involved, it is okay. First thing, which is more common? More common is this presentation. Left side colitis is most common. Okay, come to this, if the patient present with E1 like proctitis, what are the symptoms? Rectal bleeding, tenesmus and urgency will be there. Just focus on symptom. If left side colitis, yes, rectal symptoms will be there plus diarrhea and abdominal cramping will be there. If extensive, so constitutional like fatigue and fever. Okay, so just remember symptoms. Now treatment. Topical plus minus oral 5-ASA therapy and steroid. Similar for left side colitis, but biologicals are rules also, and the treatment generally it's same for pancolitis. So this is again Montreal classification for ulcerative colitis, which is very important. How you will diagnose this ulcerative colitis thing? So to diagnose ulcerative colitis, clinical presentation is based on chronic symptom endoscopic finding. Colonic biopsy confirm the diagnosis. So, laboratory studies, anemia, hypoalbuminemia, increased ESR, CRP, and fetal calprotectin is sensitive marker for GI inflammation. From this slide, just remember, fecal calprotectin is the sensitive marker for GI inflammation. Other thing may be anemia, hypoalbuminemia, and ESR and CRP increased. Imaging, you will do barium enema, maybe do endoscopy, yes. Diagnosis, what are the histology? Microulceration, cryptitis, crypt abscess, mucus depletion, granuloma, fissures, full thickness involvement. suggestive of Crohn's disease because these are full thickness involvement. Okay. So this is ulcerative colitis, double contrast barium enema showing 5-year-old child with intermittent intestinal extraintestinal symptom. Small ulceration, as you can see, is uniformly in colonic circumference and starting from rectum to proximal colon. Okay, so this is basically a colonic view, and you can see the whole involvement of mostly rectal to colonic structures. Okay, so late changes in single contrast barium enema like colon is featureless, reduced in caliber and shortened. Dilated terminal ileum loop backwash ileitis is seen. Basically, what we able to see is the colon. Colon is featureless, reduced in caliber and shortened, and dilatation of terminal ileum backwash ileitis. This image of contrast enema is very much important and for example. Okay, are there any pediatric ulcerative colitis activity index? As we saw in ulcerative colitis, Monterey classification is seen as classification. Then Mayo score is for endoscopy. Okay, for again, this is pediatric ulcerative colitis activity index. So, just remember what are the component. I will highlight for you: abdominal pain, rectal bleeding, stool consistency of most stools, number of stools per 24 hours, nocturnal stools, activity level. So, these are 5 components. Which component is not in this component? Like this question is potential question. Okay, how you will manage ulcerative colitis? So ulcerative colitis can be managed by aminosalicylate 5-ASA. This is first line treatment for mild or moderate ulcerative colitis. Sulfasalazine is used less. Mesalamine better tolerated, and uh, balsalazide used in oral and rectal form of proctitis. So 5-ASA helps in remission and prevent recurrence. So just remember this mesalamine is better tolerated than sulfasalazine. So 5-ASA is the first line treatment of mild to moderate UC. Okay, so this is very important for mild to moderate ulcerative colitis. What is the first line management is aminosalicylates 5-ASA, and mesalamine is better tolerated. So is there any role of steroid? Yes, corticosteroids are used for moderate to severe flares but for not for maintenance. So prednisolone we can use. Okay, so journal side effects of steroids like poor growth, adrenal suppression, osteopenia can be seen. Are there any immunomodulator available? Yes, immunomodulator like azathioprine 6 mercaptopurine are used. Are there any biologicals? Yes, infliximab and adalimumab are used. Okay, important thing. The new drugs in this list like vedolizumab, this is integrin inhibitor, and ustekinumab, interleukin 12 or 23 inhibitor for refractory cases. This is very important. Again, probiotics are useful in preventing pouchitis after colectomy. So, immunomodulators and biologicals like newer biologicals like vedolizumab and ustekinumab are used. And for probiotics like they help in preventing pouchitis. Okay. Are there any surgical treatment for ulcerative colitis? Yes. Colectomy. When colectomy is done in ulcerative colitis, it is done in intractable cases when complications like toxic megacolon arises. Ileal pouch anal anastomosis, okay, is done. Temporary ileostomy is done. Complications like pouchitis in 30 to 40% cases treated with oral metro, cipro and plus probiotic. Okay. So, colectomy is one of the treatment option of ulcerative colitis which is refractory to medical management. Supportive care, obviously you have to support the patient. Prognosis. Prognosis actually, because it is complicated by remission and relapses, prognosis is guarded. Cancer risk is increased after 8 to 10 years of disease duration. So we discussed also we have to do this monitoring of cancer in UC cases after 8 to 10 years. Surveillance obviously 8 to 10 years we have to do. Okay, so this was it for ulcerative colitis. This was exhaustive discussion including every aspect of ulcerative colitis. So just keep in mind common features of IBDs, the differentiating feature in form of table, and we have discussed ulcerative colitis. Uh, Keeping this information in mind, just differentiate the next discussion point of our topic, that is Crohn's disease. Just differentiate from ulcerative colitis. Just take a pause and recollect things. Now we are going to Crohn's disease. So Crohn's disease is also called as regional enteritis, granulomatous colitis. This the terminology important. Regional enteritis and granulomatous colitis is in pediatrics. So Crohn's disease is idiopathic disorder. It involves the GID from mouth to anus. This is important. In contrast to ulcerative colitis, which is more colonic involvement, the Crohn's disease involved mouth to ulcer. Okay, so it involves any region of GIT. Lesions are mostly transmural and often skip areas are present. So basically, it is so extensive that it is actually starts from mouth to anus and also cover all transmural with skip areas. Okay, so this is pediatric population is more extensive involving ileum, colon, sometimes upper GI tract in 30% of cases. So this is again important. Upper GI tract is involved in 30% of patients in pediatric population. 50% have ileocolitis, 20% have exclusive colonic disease in contrast to UC 100%, and small bowel involvement is seen in less common in children. Okay, so epidemiology, bimodal presentation as of IBDs are bimodal. First peak in teenage years, second peak in older adults. So like 10 to 20 years and 50 to 80 years. So clinical manifestation, because inflammatory, structuring and penetrating phenotypes. So these are phenotype means in Crohn's disease more complications are there than ulcerative colitis. So if it is small bowel disease, then symptoms of obstructive symptom will be there. If it is colonic disease, inflammatory symptoms will be there. So what are the common symptoms? Growth failure, delayed bone maturation, delayed sexual development are more common in this Crohn's disease. Decreased height velocity in 88% of prepubertal patient. So this is important. Growth faltering, growth failure is more common in Crohn's disease. Okay, perianal disease, important, is more common in Crohn's disease, tags, fistula, deep fissure, abscess. Okay, so this is very important. The rectal and colonic involvement is more common in ulcerative colitis, but the perianal disease is more common in Crohn's disease. Penetrating disease, as we can see, the more complications are seen in Crohn's disease like fistulas, like enteric, enterovesical, intra-abdominal abscess are more common in this condition. Okay, again this important thing, what are the extra intestinal manifestations of this condition like Crohn's disease? Just remember for the comparison we will see for UC, like postgraduate went to Supreme Court for case. So this is for ulcerative colitis. Okay, so like pyoderma gangrenosum, sclerosing cholangitis, chronic active hepatitis, and one more thing we'll see is more common in ulcerative colitis. So, in view of this extra-intestinal manifestation of chronic disease, Crohn's disease, will compare oral aphthous ulcer because it involves mouth to rectum. So, oral aphthous ulcer are more common in Crohn's disease. Arthritis is more common. Erythema nodosum and distal clubbing, episcleritis and uveitis. Renal stones are more common. Even gallstones are more common. Venous thrombosis is more common. And metastatic Crohn's disease are more common. So just remember these. So complications like short bowel syndrome, bile acid malabsorption, vitamin B12 deficiency, cholelithiasis, and oxaluria. So which IBD is more predisposition with renal stones, that is Crohn's disease. Okay, this is layman score. Okay, so this is layman score of CD. So this is straightforward question. Layman score is used for severity of Crohn's disease for the stricture, fistula, surgery, stricture. So just remember, layman score is used for Crohn's disease. For the differential diagnosis, as we seen earlier in case of ulcerative colitis, also infective enteropathies, celiac disease, GRD infection, small bowel lymphoma, recurrent abdominal pain, lymphoid nodular hyperplasia, and periappendicular abscess. Just remember, Yersinia enteropathies sometimes mimic Crohn's disease, celiac disease sometimes mimic Crohn's disease, GRD infection cause Crohn-like symptoms, very much important. Small bowel lymphoma mimic Crohn disease, and sometimes lymphoid nodular hyperplasia. For this slide, what is important actually? Yersinia, celiac disease, Giardia infection, and small bowel lymphoma mimic the Crohn's disease spectrum. Okay, how you will diagnose this Crohn disease? Like symptom, we have seen laboratory studies as any IBDs, anemia, CRP, ESR elevated, and fetal calprotectin, which is sensitive marker for GI inflammation seen in both UC and CD. Oh, imaging, you will do abdominal X-ray, that is fine. Endoscopy, you will do biopsy. This is important. This is diagnostic also. Cryptitis, crypt abscess, granuloma, and mucosal inflammation are more in this Crohn's disease. So how you will differentiate it from ulcerative colitis? So as we discussed also, Crohn's disease involves transmural inflammation, and granulomas in biopsy are more suggestive of Crohn's disease. Okay, so this is actually pattern of involvement of this Crohn's disease. If the pattern of involvement, like you can see, uh, in this condition, this is distal ileum. This is actually A, as we will see. Okay, A, this is the first image which is actually more common in this. This is actually MRE image with fat saturation of gadolinium chelates with enhanced distal ileum. So in distal ileum, and in B part, in this image, as we can see stricture, and we can see this is enteroenteric fistula. Okay, so basically in these images, these are actually ileal involvement, this is ileal involvement, this is stricture, and this is fistula. So how the symptoms will vary? If ileal involvement is there, then diarrhea, abdominal pain, weight loss, low grade fever, fatigue, malabsorption. This is the symptom features. If stricture means obstruction is there, postprandial pain, bloating, nausea, vomiting. This is again important. A patient present you with postprandial pain, bloating, nausea, and vomiting, think of Crohn's disease. If fistula is there, the symptom will depend on fistula like enterourinary fistula, rectovaginal fistula, and enteroenteric fistula. Okay, stenosis in Crohn's disease, MR enterography is shown here. In this MR enterography, the Crohn disease restricted to terminal ileum with inflammatory stenosis. So these are stenotic pictures from Crohn's disease. Okay, so 19-year-old child presented with bloody stool and later diagnosed with IBD. Abdominal X-ray. This is abdominal X-ray which is showing classical thumb printing involving distal transverse colon, splenic fracture, descending colon. Okay, representing some mucosal edema seen in colitis. So this is thumb printing, thumb printing seen in CD. Okay, it can be seen in ulcerative colitis also, but it is more seen in Crohn's disease. Okay, again the important 12-year-old child with weight loss and bloody stool diagnosed with Crohn's disease. Small bowel follow through barium examination show classical features of Crohn's disease like mucosal thickening, irregularity, and nodularity cobblestoning of terminal ileum and distal ileal loops. So what we have to remember from this image, basically we have seen cobblestoning, which is this image. Okay, this is cobblestoning, and this is actually mucosal thickening and irregularity in this image. Okay, again this image is of Crohn's disease. Just skip this, and these are actually on PET. These are active and chronic changes of PET. Just go through once. Okay, what is the treatment of Crohn's disease? Again, amino salicylate 5-ASA is first line for mild or moderate disease. Same like ulcerative colitis, amino salicylic acid is first line. Corticosteroid for same like ulcerative colitis used for acute flares, not for maintenance. Immunomodulators like azathioprine, 6-mercaptopurine, and vedolizumab and ustekinumab for refractory cases, same as ulcerative colitis. Infliximab and adalimumab are used. Surgical treatment, yes. Colectomy is the option for intractable cases and complication. Short bowel syndrome management, strictoplasty. Nutrition support we have to give. Okay, so prognosis. This having chronic relapsing course with period of remission and exacerbation, growth failure during puberty, short bowel syndrome, and cancer risk are there. Okay, so diagnosis we will see. Okay, how we will diagnose this condition like growth failure, abdominal pain, right lower quadrant mass, perineal abscess. How we will diagnose? Laboratory finding we have seen also, endoscopy finding we have seen, radiological studies we have seen, treatment we have seen. Okay, okay. So yeah. So just to more into the detail of this like treatment option. Okay, treatment. So just 5 amino salicylic acid and mesalamine. This is 50 to 100 milligram per kg per day. Antibiotic metronidazole is used for perianal disease and infectious complication, and probiotics are used for pouchitis. Prednisolone is 1 to 2 milligram per kg per day for acute flares, and budesonide is 9 milligram daily for mild to moderate ileocolic disease. Immunomodulators like azathioprine, if you want to remember the dose, yes, you can remember. Methotrexate is used, infliximab used, okay, adalimumab, vedolizumab, and ustekinumab. Okay, exclusive enteral nutrition is used. So, partial enteral nutrition and surgery we have seen. So, yeah, prognosis colonic cancer risk is more. So, after 8 to 10 years, colonic risk is important. Management of extraintestinal disease is important. So, for this, again, what we have to do, just go through the differentiating features of ulcerative colitis and uh, this again. So, I'll go directly to those tables which showing the differentiating features. Again, after having discussion of ulcerative colitis and Crohn's disease, just go through these things like ulcerative colitis and Crohn's disease difference, and you will remember, you will understand all these things. So this was exhaustive discussion for ulcerative colitis and Crohn's disease, which are part of inflammatory bowel disease spectrum. Just take a breath and go through this video again and just try to remember, understand. You will get a nag of it, and this is will be good for you. Euconium ileus. We'll discuss some another topic of this amazing series. Till then, do share, like, and